It's a pleasure that we have come on the 10th day of our medical knowledge update. And today Rahul is going to speak to you on bronchial asthma and allergy. So here to you, Dr. Rahul. That's it.
Yes, good morning everyone. Today we'll be discussing briefly about asthma, and you'll understand how asthma works, how we treat asthma and what are the types of asthma. And these lectures are being held and guided under Dr. Sharda Jain. Without much further ado, let's start the topic. So in the picture, the first thing we'll just focus this picture. So from overview, when we see this picture, on the left side I see a normal bronchial tube, while on the right side I see a inflamed bronchial tube. So the point to be noted just from this picture is, the first thing is the alveoli in both are normal, so it is not a disease of alveoli. Secondly, we see it is a disease of bronchi and bronchioles. Then in the second picture, what is difference from the first picture is, in the first picture bronchi is open, in second it is tightened by the smooth muscles, and also even after it's chronic process, and it's tightened, and also the inside there is mucus and swelling, so that is also causing the obstruction along with the tightened smooth muscles. So we'll have this. So now we have the pre-idea that what is actually difference morphologically and anatomically between a normal tube and an asthmatic tube. So going over to the content. So as I already told that this is how we'll be discussing asthma. That first we'll study definition, pathophysiology, types, and then we'll move on to management and treatment. And in the end, we'll just discuss status asthmaticus, an interesting entity. So coming on to definition, again, I put a definition where each and every word means something and is equally important to define a disease. So the first is, it's a chronic inflammatory disorder, which means to say that chronic inflammatory, first of all, when we talk about asthma, it is an episodic airway obstruction. So we say that since it's an episodic airway obstruction, whenever the patient has attacks, he will be symptomatic, but in between the attacks, the patient will be normal. But this line is incomplete because it is a chronic inflammatory disorder, which means that over few years, when the chronic inflammation persists, the period of normalcy also will become not as good as the period of normalcy which were few years back.
Correct.
So it's a chronic inflammatory disorder, which means that the goal of a treatment, first of all, should be to stop this chronic inflammation and to make the patient symptom free. So there are two things here. I will give drugs which are making my patient symptom free, and I will giving the drugs which are inhibiting the inflammation. So giving the drugs which are will inhibit the inflammation will not help in my symptom at that point, but it will help me to control the progression of the disease. So with this knowledge, I will like to read the definition again, that it is a chronic inflammatory disorder of bronchial tree. So since it's a disorder of bronchial tree, it is not a disorder of alveoli. And it is characterized by episodic airway obstruction, which means the patient is only symptomatic during episodes, and in between the patient will be normal or better than the time when he's in episode of airway obstruction. And this chronic inflammation over the period of maybe 5 years or 6 years down the line will cause airway hyperresponsiveness. So this airway hyperresponsiveness means, if suppose a normal person who is not prone to asthma inhales an allergen or maybe pollen, so there is maybe similar response that the patient also coughs, because that pollen is an irritant, but it is the airway is not as hyper responsive as it is in case of bronchial asthma. So bronchial asthmatic people have an exaggerated response to something trivial such as pollen. So again, noting on the picture that on the left side I can see normal lung. So the airway is huge. But on the right side, if I notice, so in between the rings, I can see hypoplastic muscle, hypoplastic and hypertrophic muscle. This muscle is getting tightened, and then it is also thicker in size, and even inside the lumen there is solar lining and excess mucus. So this solar lining and excess mucus is part of chronic inflammation, while the muscle tightening is part of episodic airway obstruction. So yes, we'll discuss this further in this presentation. And going on to pathophysiology, so most of the time, first of all, there are two types of asthma. So the first type of asthma is mainly because of allergens that we see commonly in children. And so basically it is because of allergies. So any kind of allergies are possible: dust mites, even dog fur, cat fur, pollen, smoke, mold, cold, and all these things. So what is important to understand here, that even cold air and even exercise can trigger asthma. And then there is genetic factors. So family history is very relevant. So basically pathophysiology works like that: a patient or any person who has genetic factors and he starts smoking, or he starts stressing, or he has some viral infection episode, and so this is a trigger for the starting of asthma, and then he gets exposed to any allergen. And there are some cases where the allergy is only seasonal, so there are certain pollens or certain plants which only release pollens during certain season in a year, so the person will only be symptomatic during that phase of the year. So
Rahul, what is there in the first line? Furry. What is furry?
Furry animals.
Okay, okay. Furry animals. Okay.
Yes. So so first, what happens that these are the trigger factors. So afterwards, there is airway inflammation. So there is something called as T helper 2 cell mediated response. So and then they get sensitized. They will release inflammatory mediators. Those inflammatory mediators are the cause of all the symptoms. So correct. Yes, this is the picture which summarizes the whole thing. So there is one allergen. That allergen got inhaled into the respiratory tract. That allergen was taken upon by CD4 T cell. That CD4 T cell made IgE, the immune antibody. That antibody went and sat on mast cell. So this is the point to be noted, that when the person gets exposed first time, the response is not very severe. It's very mild. A person won't even get to know. But subsequent time, the response will keep increasing. That is, the patient will become even more symptomatic with the response. The reason behind is that Ig is already sitting on the mast cell. The moment IgE comes in contact with a specific allergen, it causes degranulation of mast cells, and eosinophil granules split up, releasing all the cytokines, leukotrienes, histamines. Okay. So all these cytokines will cause what? First symptom is bronchoconstriction. So this cytokine storm or this all the inflammatory mediators will cause bronchoconstriction. So bronchoconstriction, since the bronchi will constrict, the patient will present as dyspnea or breathlessness because he won't be able to breathe comfortably. So I'll just mention here what is actually dyspnea. The exact term dyspnea in our medicine we call it. It's like uncomfortable presence of your own breathing. So normally we are not aware that we are breathing, but a dyspneic patient is always aware that he is getting some uncomfortable. He's getting uncomfortable while breathing, or he's breathless.
Okay.
Then mucus production and wheezing. Wheezing is just like when we play flute. It's because the flute is very thin. So that's why it produces sound. So similarly, the bronchi constrict, and whenever the air passes through it, it produces sound. So this musical sound is wheezing. So whenever we hear an asthmatic patient, there is kind of a musical quality to their breathlessness. Whenever we see them breathless, then there is a chest tightness, and mucus production is again because of all the inflammatory mediators. So I hope this type 1 asthma pathogenesis is very clear. Very clear. The allergen reacts with CD4 T cell. That CD4 T cell forms IgE that goes and sits on mast cell, and whenever next allergen exposure is there, that just IgE reacts with it, cause this mast cell degranulation. So with subsequent attacks, the rapidity of symptoms increases.
Correct.
So this is happening when there is a first inflammation or in the initial stages of airway inflammation. So, but over the time there is something called as airway remodeling. So it's been shown that even though after some time allergen is not present, but the inflammation continues. So this is where the definition first line comes, that it is a chronic inflammatory disorder. Since it is a chronic inflammatory disorder, this airway remodeling phenomenon happens. So what is airway remodeling? That in this picture, this summarizes it whole, that there is I can see that airway remodeled, that there is mucus hypersecretion in this airway, goblet cell hyperplasia. So goblet cells are the one which secretes all the mucus. Even in stomach, goblet cells secrete the mucus. So, and then there is fibrosis and thickening of the basement membrane. So that will also trigger hyperresponsiveness. So, and there's hyperplasia, hypertrophy of smooth muscles. So with time there is remodeling of airway. So we need to know this phenomena well, because we need to stop this airway remodeling in any patient. So we need to detect asthma early, and we need to start treating it to prevent this airway remodeling, because as there is airway remodeling, the disease will progress and symptoms will become more severe, and it will be harder to control the disease.
Correct.
So the main phenomena in knowing this pathophysiology is to control, to know that there are two stages of there is first stage of airway inflammation, and then there is airway remodeling, and our goal of the treatment is to control the airway inflammation and prevent airway remodeling, which occurs over the time.
Okay.
Then going over to the types, there are two types of asthma: extrinsic asthma and intrinsic asthma. So I discussed the mechanism of type 1 hypersensitivity, that is extrinsic asthma. So this picture we see is the mechanism of type 1 hypersensitivity. So allergen coming, causing CD4 T cell stimulation, Ig production, Ig sitting on mast cell, then whenever Ig exposed to allergen causing mast cell degranulation, it is part of type 1 hypersensitivity. While intrinsic asthma, the mechanism is diverse. So what is important in this mechanism is intrinsic mechanism. Intrinsic asthma is the asthma which occurs at any time, even in adults or old age. So with no history of asthma before, and suddenly an elderly person becoming asthmatic or can present as asthma, I will say that the patient is having intrinsic asthma, and it is not associated with allergens. So this type of asthma is not associated with allergens, and it occurs in old age. So a childhood asthma, the major trigger, the dust and pollen and allergens. So my first advice goes to them is avoid allergens. The therapy which will be the best for those people will be avoiding allergens. So we need to identify the allergen factor, and we need to ask them to avoid that. But for intrinsic asthma, majorly adults or old age which are presenting as first episode of asthma in old age, the strategies which are anti-allergens or avoiding the allergens won't work that much. There the triggers are mainly stress, exercise and cold air. So we need to ask them to do a warm-up maybe before exercise, or taking their inhaler just before exercise if they want to perform the exercise, and not going to the places where there is cold air. Wait for the temperature to outside become less. So differentiating extrinsic asthma and intrinsic asthma becomes very important, because the triggers are very different and the treatment is also very different, and the advice we give to the patient again is very important. It's very different. So those things become important. That's why we need to differentiate them. Then antibody and mast cell, as we already discussed, that in extrinsic cell there is IgE involvement, but intrinsic there is no IgE involvement. So we can do this objectively by doing the test IgE measurement, and it will be elevated in case of extrinsic asthma, but it will be normal in intrinsic asthma.
Okay.
Then history of allergy will be present in extrinsic asthma, but there will be no history of allergy in intrinsic asthma. So these people who have extrinsic asthma, they will give history that they have skin allergies also, or maybe some type of other allergy also. So we know that, okay, our diagnosis gets confirmed, or it's like an adjuvant to our diagnosis.
Correct.
And there is family history also in, so the whole family, even the father will have asthma, the child will also have asthma, and the onset is usually childhood. Then going on to clinical features. So the clinical features are very easy to understand. That is, every episode of asthma, the allergens will cause bronchoconstriction. That bronchoconstriction and mucus hypersecretion will cause same symptoms every time. So when I'm talking about someone presenting initial few years of asthma, there will be wheezing, dyspnea, and chest tightness, and in between the attacks, the patient will be completely normal. So the history will go on like that. They inhaled something, or maybe they got exposed to something, and then suddenly they started wheezing, dyspnea, and chest tightness. So it should be a sudden breathless. It won't be like that. It will not keep on going for days together. It will just be like a attack of lasting for some time, and then there will be episodes of normalcy in between the attacks. While on the other hand, over the few years when there is airway remodeling has happened, it forms chronic asthma. So chronic asthma the symptoms will keep on persisting for whole day. They'll get aggravated, then they'll get controlled, but period of normalcy won't occur. So this is the reason I need to control the asthma in the initial stages itself. And status asthmaticus, that we'll discuss in the end. It's an interesting entity. It's the most severe form of asthma. So episodic asthma, this much only about clinical features. Then going over to the investigation. So what investigations we do when we are investigating someone with asthma? So first is lung function test. So first of all, I need to confirm my diagnosis that it is asthma. So how will I confirm my diagnosis of asthma from other diseases is that I use this point called as episodes of normalcy in between the attacks. So episodes of normalcy in between the attacks. So and also that asthmatics have this phenomena called as airway remodeling. I already know, and airway inflammation. So I will check their FEV1 and FEVC, and I will discuss that what is FEV1 and FEC, and I will then give them bronchodilator, and then I will check it FECV and FEC1 again, and then I will see how much it has improved. So if the patient's airway is improving more than 12%, there's more than 12% increase in FEV1 and FEC or 200 ml objectively, then I know that it is asthma, because asthma responds well to bronchodilators, while all other diseases don't do this much. 12, that is a value of 12%. So even my COPD and all will improve with bronchodilator, but not 12% immediately over the span of 1 minute. So what is FEV1 and FVC? So yes, we'll discuss it. So basically FVC in simple language is, I'll ask the patient to inhale how much ever possible air inside, and then I'll ask him to exhale after taking deepest breath possible and as fast as possible. So that becomes my forced vital capacity. And FEV1 is that how fast in the first second of the forced expiration how much air of the FVC he is expiring. So if I see this diagram, basically the whole thing is forced vital capacity. On the right side, I can see that exhaled volume I'm measuring, that is forced vital capacity. So basically in this figure, the patient is exhaling up to almost 4 liters. So in first second, he is exhaling 3 liters post bronchodilator, and in first second pre-bronchodilator, he is exhaling almost 2.5 liters. So there is increase of almost 500 ml just within 1 minute after the pre and post bronchodilator in the FVC. So that confirms my diagnosis of asthma.
क्या देते हैं bronchodilator?
Salbutamol.
Inhaler.
Yes. So yes, so we need to know this is the most important test in asthma, and it is still gold standard, and it is going on. It's the cheapest available thing, and it's so easy to do that you do a patient's forced vital capacity. That is, you ask them to take a deepest breath possible, then you ask them to exhale all the air, and the amount of air they exhale in the first second becomes FEV1. That percentage of FVC in first second is FEV1 and it will get improved massively with 12% after post bronchodilator. So basically the concept is that in asthma there is bronchoconstriction. So whenever if I'm trying to exhale something through a narrow tube, it will be harder. But when if it becomes bronchodilated, it will be easier. So the amount will increase. It is as simple as that. Then going over to other investigations, then I will do chest X-ray and HRCT. So mostly in case of asthma, they won't suggest anything. We are just doing them to rule out other differentials, and also sometimes, rarely, very rarely, asthma can cause bronchiectasis. So to rule out that, then we have something called as allergic test. We have to check that what is the allergen which is responsible for all these problems which is triggering the asthma. So we do this test called as patch testing. So we can see in this patient that on one side there are almost 50 allergens I have put. So I will put common 50 allergens, and on the right side I will put 50 controls. So then after a span of maybe 48 hours, I will remove these patches and I will see that to which allergen there is most response is maximum, or there is exaggerated response, and I will compare it with the control on the right hand side, and then I will get to know that the patient is susceptible to this specific allergen. So we do this skin allergic testing, and we do it on the back of the patient, and on the one side there are 50 allergens and on the other side there are 50 controls. Then I will do sputum microscopy. So there are three things which are very characteristic of asthma, that is creola body, charcot crystal, Kurtzman spiral. So I've just put the pictures that under the microscope this Kurtzman spiral looks like this and creola body looks like this. Then I will do ABG analysis. So ABG will tell me that how severe the asthma is. So the concept is very simple, that there are two types of respiratory failures. There's type 1 type of respiratory failure and there's type 2 type of respiratory failure. My type 1 type of respiratory failure is basically only hypoxia, and that type of 1 respiratory failure manifests as respiratory alkalosis. And my type 2 respiratory failure is hypoxia plus hypercarbia, that is respiratory acidosis. So I need to know that is the patient very severe, because type 1 respiratory failure is basically only hypoxia, while if the patient got very severe asthma, then he can land up in type 2 respiratory failure. So if the patient has come with acute breathlessness and I'm suspecting asthma, I need to grade the severity of asthma. I will go with for ABG analysis. And then this interesting test which is coming up, this is a new update, this exhaled nitric oxide test called as FLYOVER. So if I go back to pathogenesis here, this entity of eosinophils is there in the diagram. So ultimately eosinophil only is releasing all the cytokines which is causing all the symptoms. So this is a sure test to detect eosinophils, that eosinophils have this enzyme called as nitric oxide synthase. So if there is a massive eosinophil activity inside the lungs, then I know that the patient will start expiring nitric oxide. So that's why I measure the nitric oxide and I can grade that how much eosinophil exposure that person is having. So exhaled nitric oxide, that is we know, is the measure of nitric oxide released into the breath, and the reason behind it that eosinophil and nitric oxide synthase activity. Then so we are clear about the allergic skin testing on the back, and on the left side I just put the picture of creola body and Kurtzman spiral and the charcoal lead and crystal. These are characteristics of sputum in the asthma. If these three are present, we know that it's the sure diagnosis of asthma. It's basically they are the dead cast. They're dead casts. So then going on to the treatment and management. So first I'll mention the drugs available and mechanism they're working on. So first of all, we commonly know that there are beta receptors inside the lungs. So there is beta 1 receptor in the heart and there is beta 2 receptor in the lungs. So beta 2 receptors causes bronchodilation. So this we call them in the short SABA, short acting beta 2 agonist. And SABA, basically the common drugs available are salbutamol and levosalbutamol. So we commonly prescribe these syrups also, LX, LS. So this LS refers to levosalbutamol also. It's a bronchodilator. So and then LABA is long-acting beta-2 agonist, and they are the same drugs, but they stimulate beta-2 for longer times. So the mechanism is very simple. That they first of all, they are inhalers, so they have only local action. They do not cause much of the systemic side effects, and if they are short-acting, they are called as SABA, and they're long-acting, they're called as LABA. Then, as I mentioned earlier also, the LABA and SABA will only provide symptomatic improvement. But it's very important to prevent the further attacks and the progression of the disease. So inhaled corticosteroids, they won't benefit the patient in symptoms, but they will prevent the progression of the disease and also will reduce the severity and the frequency of attacks. So these inhaled corticosteroids are available in the form of budesonide, beclomethasone, and fluticasone. So they stop progression. So this point is very important. And budesonide is available as Budecort inhaler, if you know, and salbutamol and is available as Asthalin, Respules. So going on to other drugs available.
नाम जरूर लिख देना एक slide में.
Yes, ma'am. So what are the drugs available?
Available है ना, available in the market, commonly used, वो नाम लिख देना एक slide.
Okay, ma'am. So drugs available. So what are the drugs available? Other drugs available other than that? Then we can give prednisolone, hydrocortisone, and methylprednisolone available. Again, the steroids, the oral steroids, and even IV hydrocortisone is commonly available. Actually, IV H-Cort, and these drugs will also help in stopping the progression. And then even we give anti-parasympathetic also. So ipratropium, tiotropium are also benefits in bronchodilation, but they are commonly used in COPD, not in asthma, but they are still helpful. And then the last drug is we directly target the IgE. That is, there is something which blocks the IgE receptors, and that is omalizumab, and it is a monoclonal antibody, and it is very effective and only used for very resistant asthmas. So this figure down here, it summarizes basically the mechanism of all the drugs and how and where they are acting. So first of all, we have already discussed it, that IgE comes and sit on the immune cells, and then whenever the allergen comes, this allergen sits on the IgE reacts with that allergen and causes degranulation and release all the histamine mediators, which causes all the symptoms. So basically, when I give omalizumab, the omalizumab goes and binds these receptors itself. So there is no place where the IgE binds. So when there is no where IgE can bind, the degranulation won't happen and patient will be asymptomatic. Then my corticosteroids beta adrenal agonist comes and acts at the last part where the already inflammation and constriction has already occurred, and I'm trying to provide the symptom-free interval, and that time I'm stopping the inflammation. So the diagram says it all.
एंटी-जी है, IgE है, ये कैसे अवेलेबल है, इनहेलर है, क्या है?
Ma'am, actually this we don't prescribe to everyone. It is only preserved for the very resistant cases. It is a IV injection. It is monoclonal antibody, and it's very expensive. I think one injection is 50,000 rupees and all. Okay. So it is not to be prescribed. It is not prescribed usually to everyone. It is only prescribed where the symptoms are not getting controlled on possible drugs available. So what is most important in this diagram is I can see that when I give corticosteroids and beta adrenal receptor agonists and all these drugs, they act at the last part of my symptoms, at the last part of the cycle. So already so much story has already happened, that allergen has bind and all. So these drugs will provide me symptom, but they're not very good in preventing the progression of the disease. So this diagram says it all. But while giving anti-leukotrienes and omalizumab on all those drugs, they're acting on the first chain of the cycle. So they are completely stopping the cycle from the first part itself. So that makes them very excellent drugs. Then going on to the management. So these are the drugs available. So how will we use them? So the management is first of all avoiding the allergen. So this is the most effective strategy. If the patient tries to avoid the allergen, if we identify the allergen, that is maybe the allergen is smoking, then if the person does smoking cessation and does not come in contact with anyone smoking, that is passive smoking, then we can be sure that the chances of him getting the second attack will become lesser. So the most effective strategy is avoiding the allergen, any other than drugs, there's avoiding the allergen. And in the cases where the allergen is not avoided, we then eventually will give the treatment, but then the most effective is avoiding the allergen. And for the simple reason that the whole pathogenesis will stop if there is no allergen. Then if the asthma is exercise induced, then we ask the person to do warm up. And I've mentioned it before also, and if the trigger is cold air, then the patient should not go to the place where there is cold air, because that can trigger the asthma. And doing a warm up before exercise is very important. Also, to these patients, we prescribe them that they can go for taking one puff of bronchodilator, just doing their exercise, and then they can start doing exercise. Then there are GYNAE guidelines which decide the management for asthma, and GYNAE refers to General Initiative in Asthma Management guidelines. So these GYNAE guidelines, I made it very simple. The guidelines have many more things, but we need to know how to start drugs on a patient. First, we need to know that what type of asthma it is. Is it an intermittent asthma or is it a persistent asthma? So to remember that, it's a very simple rule of 2. So if they have less than 2 episodes or equivalent to 2 episodes per week, I call it intermittent asthma. And if they have more than 2 episodes in week, then I call it persistent asthma.
Correct.
So then persistent asthma is also of 3 types: mild type, moderate type, and severe type. So it's very simple that in moderate type, I'm basically practically getting 1 attack every day. So more than equal to 7 per week. So moderate asthma 1 per day, and severe more than 1 attack in a single day. And mild will become less than 1 attack per day, but less than that will make it less than 6 per week, but more than 3. So I think the way to remember it will be very easy, that we can just remember that for us, our rule of 2, for us at our level, that less than equal to 2 per week is intermittent asthma, and more than 2 is persistent asthma.
Correct.
So then what is the guideline is, if the patient is on intermittent asthma, then we give salbutamol pro-renata. Pro-renata means as and when required. So the moment, so since he has intermittent asthma, that is the frequency is less than 2 per week. Sometimes he won't even get 1 attack per week. It's the better strategy is just to give them whenever they're symptomatic, and asking them to avoid allergen and all those things. So salbutamol, intermittent asthma, salbutamol is prescribed only. Salbutamol inhaler is available as it's available as brand name, the generic name only, salbutamol inhaler. Then mild persistent asthma. So since the asthma has already gone to the persistent stage, I would like to start them on corticosteroids inhaled. The reason is I want to stop the progression.
All right.
So the most commonly used inhaled corticosteroids. So inhaled corticosteroids, first of all, the benefit is it is locally acting. So all the side effects of steroids which we talk about won't occur only in this patient. So it is only locally acting steroids, so it is very safe. So inhaled corticosteroids are my commonly budesonide and fluticasone and all those things. So I need to start the patient on inhaled corticosteroids. And then this SABA, that is salbutamol, we keep getting continued. And
भैया इसमें common नाम जरूर लिख देना.
Yes. This yes, budesonide, beclomethasone, and fluticasone, and then inhaled corticosteroids and SABA. So for moderate asthma, I will add one more thing, that is LABA. So, and then for severe persistent, I will even go for additional drugs, even maybe omalizumab. That is my monoclonal antibody, IgE antagonist, anti-IgE. So what is important here is that SABA, when I give SABA, the SABA is to be only taken when the patient becomes asymptomatic or the symptoms are not getting controlled over inhaled corticosteroids. So then going to the last entity, this was about guidelines of the treatment of regular asthma. Then what is status asthmaticus? So status asthmaticus is the most severe form of asthma, and the asthma won't stop. The patient will keep on going breathless. And this is the type of asthma which has to be managed in hospital and not in OPD, not on OPD basis. And this type of asthma is managed inside in hospital admission. The reason behind is this type of asthma is actually precipitated. It is a precipitating factor of asthma. So the patient was asthmatic and then he got chest infection or maybe lower respiratory tract infection or some kind of pneumonia, and then he becomes asymptomatic. Or maybe we can also say that the patient was asthmatic and he got diabetes ketoacidosis, then he will go in status asthmatic. So there's always a precipitating factor behind this kind of status asthmatic. So first of all, we need to control the asthma and we need to find what is the precipitating factor in these cases, and we need to treat them simultaneously. So status asthmaticus, basically there are few signs of status asthma. So the important things we can remember is, so the patient is breathless, he can't speak the whole sentence. He will be speaking in the words, and in between the sentence words he will be breathless. So this is the first sign I know that his asthma is getting really uncontrolled. Then the patient will obviously be agitated because he is not able to breathe. And then what is important is respiratory rate will be really high, and there will be the tachycardia will be high. That is normally tachycardia we say when the heart rate goes above 100, but heart rate more than 120 is sign of status asthmaticus, and they can go for hypoxia, that is oxygen saturation less than 90%. And yes, silent chest. So why there is silent chest? So whenever I'll put my stethoscope over the chest, I won't hear any breath sound. The reason is the bronchi is so constricted that air entry is markedly reduced.
Correct.
So everything goes to basics, that is bronchoconstriction. So the entry point will become so slow, so less, the lumen will become so small, that is the air doesn't get transmitted through it. That's why there is silent chest, or very minimal air entry is there, so it won't be heard on stethoscope, with stethoscope. Then there is bilateral wheezing. The mechanism is same, that is bilateral wheezing, the mechanism is same, that is whenever we pass air through a narrow tube, it causes a whistling sound or causes a musical sound, similar to a mechanism acting in flute. Whenever we play flute, so the flute is very narrow, that's why there is a musical sound coming. So similar, the patient's breathlessness will be heard as a musical quality breathlessness, which we term as wheezing. Then there is a special phenomena, pulsus paradoxus, that is inspiratory fall with blood pressure. So whenever the patient inspires the air inside, the BP falls. So that is rarely seen with status asthmaticus. But yes, it is just I've put it to just for completion's sake. But we won't do pulsus paradoxicus on a patient who is requiring emergency treatment. When we check vitals, that is heart rate going for more than 120, respiratory rate go for tachypnea, and oxygen saturation going less, patient speaking in words, diagnosis asthma, we immediately start the treatment because this is emergency.
Correct.
So when I manage status asthmaticus, the first thing again in managing a status asthmaticus is putting a nebulizer with oxygen and salbutamol. The same salbutamol we use, but in this case we will do rest use, and we use a nebulizer. And we ask the patient try to take breaths of that whatever I put nebulizer, and over a period of 20 minutes the patient starts getting better, and I will also give him steroids to stop the ongoing inflammation. So usually we use injection hydrocortisone 100 to 200 mg. We can give 100 mg safely. So if the symptoms are not getting controlled, then we can again repeat a dose of 100 mg. So if there is no improvement, we add ipratropium 0.5 mg to nebulizer. If that is also not giving improvement, then we'll add magnesium sulfate, aminophylline, and all these drugs are added when there is no improvement seen over the course of 20-50 minutes. So I will start the patient on salbutamol, oxygen, steroids, all these things, and then I will see if there is no improvement, then I will add ipratropium. If there is no improvement, I will add magnesium and aminophylline. And over these things also, if the patient is not getting improved, then I would like to go for non-invasive ventilation. So ventilatory support. Then along with doing all this, I need to put the patient on airway, IV fluids, antibiotics, and we'll see the electrolytes. So the reason is that many times it happens that patient goes in dehydration, and in any dehydration of the body, it will cause mucus thickening. Wherever the mucus is produced in the body, it will thicken. So even the respiratory mucus will get thickened, and that can cause mucus plugging, exacerbate the symptoms. So IV fluids is very important. So that is the same reason that any viral patients or any patients for that matter with lung infection, we ask them to keep their fluid status as good so that the secretions become thin and if they keep coming out. Thick secretions will get stuck in the chest and cause many complications. Then obviously treating the LRTA is very important. So because many times it happens that the patient has asthma and they get a LRTA and then they become a status asthmatic patient. So treating the LRTA is very important, and these type of patients are managed inside the hospital. Then yes, this much only about status asthmaticus. I put it in brief. Then going over to management of how does asthma and pregnancy are related. So usually there is really the pregnancy has a relatively minor effect on pregnancy, and even asthma has a minor effect on pregnancy if the asthma is controlled. But asthma, the asthma patients who are already asthmatics, their asthma worsens in pregnancy. The main reason behind it is that lung volumes get affected in pregnancy. So as the pregnancy goes forward in the trimesters, the diaphragm diaphragm keeps going up and the lung volumes become less, and then already compromised patients, bronchoconstriction already happening, they will go for asthma worsening. So then there is associated increase in incidence of preeclampsia, neonatal mortality, pregnancy-induced hypertension, and complicated labor and IUGR. So what I could understand is that asthma at certain point will cause hypoxia, and that whenever there is hypoxia, it can cause incidences of preeclampsia and pregnancy-induced hypertension. So that is why the preeclampsia and pregnancy-induced hypertension are associated with increased incidence of mortality, and then there is IUGR because the child won't get oxygen well. Then the treatment guidelines remain same. It is better to go for the usual drug and not try anything which has not been tried so much on patients, because pregnancy is a very complicated state and it's a state of altered physiology. Then managing the severity and controlling the disease is the most important. If the disease has been getting controlled and the severity is being controlled from the first day of the pregnancy, then there is a relatively minor effect of asthma on pregnancy. So, ma'am, would you like to add a few words on asthma and pregnancy?
I think very rightly said that asthma gets aggravated during pregnancy. There are many factors to it. You told that the vital capacity of the lungs decreases with increasing pregnancy. But I think, these days people are very apprehensive. They live in nuclear families, there's nobody to guide, and they find, a consulting doctor every day becomes difficult, But I think, they require a very good counseling session, and they must do the prevention part. They must increase the lung capacity of they must do yoga, pranayama are very, very important to such patients. And I think once these people do it, and I feel that, the meditation also helps. Once they keep their mind calm, things become easy. And very rightly said by you is that allergens or trigger factor has to be stopped. Trigger factor has to be stopped. Trigger factor has to be stopped.
So with this, I conclude our session. I hope everything was very clear.
It was very clear. The only thing I will suggest you is that, before Malti puts it for circulation, just add the drugs which are available commonly. So I think it will take you a minute. Let her add it in the last slide. Last slide only, what are the drugs available? Am I clear?
Yes.
So I think it becomes easy for people.